Hello and welcome to Aspire's podcast on chronic pain. Today, my name is Claire Boothroyd, and today I have Dr. Jane Berryman with me. Now, Dr. Berryman is a Queensland-trained anaesthetist and a specialist pain management physician with a subspecialty interest in female pelvic pain management. In 2017, she helped establish Queensland's first persistent pelvic pain clinic in Brisbane, and more recently, one at the Gold Coast. She's been working in the area of advocacy and consulting with Queensland Health statewide planners towards improving access to early intervention and high quality care for all people with persistent pelvic pain through the whole of Queensland. We really do have a great speaker and a great knowledgeable thought or resource today in Jane. So welcome, Jane. I'm very delighted to welcome you here.
Thanks, Claire. Thanks for your lovely introduction. It's a pleasure to be here.
Thank you. Can you tell us a little bit about what chronic pelvic pain is?
So I think, I guess historically, we've been very focused on peripheral mechanisms for persistent pelvic pain or chronic pelvic pain. But I think what we're now observing in some of the literature that's coming out in the pain space is that what we're actually trying to manage is a complex neuroinflammatory condition. So I would say of all of the persistent pain disorders that I manage, including back pain or fibromyalgia, that persistent pelvic pain is actually the most complex of these conditions to manage, purely because of the, again, I say the word complex, and I'll keep saying complex because it is very complex. The visceral convergence and hyperalgesia, so the cross-sensitization of the pelvic organs that starts to occur from things just like primary dysmenorrhea. There's just a paper published in Pain Today talking about some of the central changes in people's brains with primary dysmenorrhea. The viscerosomatic convergence, so we're getting pain from muscles around the area, as well as the peripheral and central neuroinflammatory changes that occur, so that we end up with a complex interaction between all of the pelvic organs, not just the gynecological contribution, but also this pain system hypersensitivity, which is an amplification process occurring peripherally, as with peripheral nociceptors, as well as centrally in the spinal cord and also the brain, as well as the descending inhibitory pain pathway dysfunction that occurs with that. So it's a lot more complex than it appears on surface, and how we've treated it historically as a primarily, a lot of the time, gynecological lesion-focused condition.
So we will come back to the inflammatory component of that in a moment, but I think there were some terms in there that were a little foreign to me as a gynecologist. I think you used a term, visceral hyperalgesia. Was that the term you used?
Yeah.
Can you tell me what that means?
So what that means is, so hyperalgesia is pain out of proportion to that you would expect to any given painful stimulus. So, for example, distension of the bowel or distension of the bladder, or nociception inflammation from painful periods. You get an amplification of those processes, so you get more pain to any given stimulus.
And you then also mentioned about somatic. Can you take us through that? Muscular component.
So somatic structures in the pelvis are things like the skin, so vulval tissue, vagina, and also the pelvic floor muscles, which are often also involved in a kind of, this viscerosomatic, so a cross-sensitization between the organs of the pelvis and a secondary somatic response to that.
So, and how does this evolve, and how does it relate to endometriosis?
Well, I think some of the literature is suggesting that, and we know that women are more likely to get a persistent pelvic pain state purely because we have a nociceptive inflammatory state every month. And so we're more likely to, have this repeated nociceptive input causing the centrally mediated and the convergence of the organs in the pelvis and amplification process inside there. So yes, we are more likely to get them. Why do some people get this complex neuroinflammatory state associated with persistent pain, and why others don't? We don't know yet. Um, we yeah, so I feel so so they get they sorry, I'm just going back to your question again. Why do some people get this pain and why some people don't? We don't know, but we certainly also do know that there is a link between adverse childhood events and so possibly some kind of priming event that happens in early life that might you know prime some of the immune cells of the central nervous system to become dysfunctional when exposed to repeated stimulus from something like dysmenorrhea or recurrent urinary tract infections or a gastrointestinal illness.
Okay. And obviously, endometriosis being
Mm.
associated with inflammatory
Yes,
conditions,
yes,
it's
yeah,
is it it's not the cause of it. You're implying that it can sort of be a perpetuator or an amplifier. Is that
yeah.
correct?
Yeah, so I think so with endometriosis is complex, I think, because we know that there are, and you as fertility people would know that there are a lot of people who have endometriosis but no pain and they just present with fertility concerns. And then there are other people who present with minimal to no endometriosis and significant pain, which probably again speaks to this complex neuroinflammatory state that occurs with menstruation, probably a lot of the time. Um, yeah. I think the other thing we know about endometriosis is that it is actually associated with other chronic overlapping pain conditions. So things like irritable bowel syndrome, migraines, temporomandibular joint dysfunction, fibromyalgia, chronic lower back pain, all of these things actually have a complex genetic link to conditions like endometriosis, which again probably speaks to the centrally mediated mechanisms of the pain experience rather than the lesion itself.
Mm. So it's sounding to me like surgery for endometriosis in the times that it doesn't seem to work in treating the pain, that sort of all
Yeah,
fits together because
yes,
of chronic pain syndrome that we might,
yes,
as gynecologists in the past, not actually recognized. Is that
yeah,
a fair thing to
yes,
say?
yes. And I think, so what you've done is remove a possible nociceptive contributor to their experience of pain, but all of those other neuroinflammatory changes and the cross-organ sensitization remains. So unless we treat those things probably prior to surgery to get a better outcome, then the pain will stay or will recur, within 6 months or 12 months after surgery, particularly for endometriosis.
Mm. So really, we need to be diagnosing the chronic pain syndrome in
Mm.
women who have pelvic pain before we operate on them. Is that what you're
Yes,
saying? And
yes.
and,
And,
and I
I guess
suppose,
that, yeah, so gone.
I was going to say that of course acute surgery makes acute pain, so that
Yeah,
if they're sensitive to it, they're
correct. And you're
yeah.
resecting peritoneum and and around sensitized organs. So that's pretty painful surgery. So again, I guess optimizing things that you can optimize with regards to their persistent pain and all their pelvic organs and their pelvic floor function. And then mental health, which is another contributor to the pain system sensitization, just to help them understand what's going on and, so that they do get a better outcome from surgery, particularly when it comes to endometriosis, because we don't want to be doing repeated laparoscopies. We know that it's a law of diminishing returns. The more laparoscopies you do, the more likely they are to end up with a persistent pain state. Plus, then they have adhesions as well. So
Mm,
optimizing their pain state's a really important part and an important conversation to have with people before surgery.
mm. You mentioned some. So, how do we recognize chronic pain syndrome as gynecologists?
So I think asking about absenteeism with periods. So are they needing to take time off work? Does it affect their function? Do they asking about all of the different organs inside their pelvis? So asking about their bowel function, they might say it's normal, but if you ask a little bit more, what is normal? They might say, I pass a bowel motion every 7 days. That's obviously not normal.
Mm,
Their bladder function, asking about nocturia, frequency, dysuria, asking about pelvic muscle spasm, which often occurs. They kind of have a higher tone in their pelvic floor, which can sometimes flick into spasm in the context of period pain and also stress, emotional stress. So that kind of stabbing unilateral pain that they say is in their like they call it ovary pain because it's kind of it lateralizes to one side or the other, can go down the front of the thigh. Asking about other things that we know are correlated with central pain disorders. So asking about their sleep, asking about their mood, asking about other coexistent pain disorders like irritable bowel syndrome, temporomandibular joint dysfunction, fibromyalgia, back pain, these kinds of migraines, these kinds of
mm,
conditions that we know are centrally mediated.
mm, mm. And obviously, if we recognize chronic pain syndrome and we have to do things like, say,
Mm.
IVF, which is quite
Mhm, mhm.
uncomfortable for even patients who don't have chronic pain syndrome, how should we proactively manage that, Jane?
So I think one of the important things is validating their experience. So you might feel that they have pain out of proportion to someone who potentially is not sensitized. They might actually feel some shame and that they're not strong enough or they're needing more pain relief than the average person. I think helping people understand that this is a complex neuroinflammatory condition, that it's not unexpected for someone who's got some sensitivity to require different types of analgesia or more analgesia, and that everyone's individual. They have individual requirements for that. They tend to be a little bit opioid insensitive. So thinking about other things that might be helpful for them in that period of time. They may also be a little bit more anxious, potentially, given that they may have had some difficulties in the past. And I know that sometimes women are coming repeatedly, and the anxiety and the stress associated with a lot of these repeated procedures can also exacerbate things. They may also have some pelvic floor dysfunction, so looking into those things as well, involving a pelvic floor physio if you think that that might be the case, particularly for patients that have dyspareunia. Um, yes, so I think understanding that, and I think the important thing is that you validate their experience, because a lot of these women have a history of being repeatedly invalidated and told, "Oh, it's fine. I don't know what you're worried about. Your pain can't be that bad." So that's really, really, really important.
Mm. Look, thank you. That's been a very interesting exploration of a condition that I think 20 years ago gynecology wasn't in the gynecology textbooks in any shape or form, Jane. It's I
Mm.
think some of us were a bit suspicious about it,
Mm.
suspicious about the childhood trauma and
Yeah.
some kind of triggering an event. And I think as as doctors, it makes us really, it seems to give an imperative that we should always treat pain well, shouldn't we? We
Yes.
shouldn't let
Yeah.
patients
Early
suffer.
intervention is better. Early intervention is better. So managing dysmenorrhea early, early anti-inflammatories if they don't want to be menstrually suppressed. Um, I think early management to prevent chronicity is the best thing, and asking the questions about all the other organs. I know that's not your remit, but getting to know the pelvis a little bit more and referring on appropriately. Pelvic floor physios can be an incredible source of not just pelvic floor down training, but also pain neuroscience education. So helping the patients understand what's going on in their pelvis so that it's a little bit less scary and a little, that can reduce the amplification. The other thing I meant to tell you about the identifying this centrally mediated pain is there is a tool called a central sensitization inventory, which is a tool that's available widely online, which is a 26-point questionnaire for patients to fill in, and it will give you an indication of the degree. It's a well-validated tool, the degree of central sensitization or nociplastic pain, we call it, and how much that might be contributing to their experience. And sometimes that's quite helpful to present that to patients and say, look, this is suggesting to me that you might have a lot of this chronic neuroinflammatory pain system hypersensitivity. How about we look to treat that before we go and do more surgery if they've got a lot of, so that it can be quite a helpful validating tool itself as well.
Well, there are so many take-home messages, Jane, from this one. I'm going to attempt to summarise them, probably very badly, but I think we all need to think about chronic pain syndrome, think about whether the patient has it before we initiate pain-inducing procedures, which may be as simple as IVF, it may be gynecological surgery, but we do need to take the history in, and we do need to get help from a multidisciplinary team, by the sound of things, that play
Yes.
pelvic floor physiotherapists and probably pain physicians if they're available in the perioperative period. It has been and I think this is going to be a space that changes, isn't it, Jane, as we move into the future? So
there is a lot of neuroscience research happening. It's a very exciting space. Like you said, lots have changed in the last 20 years.
Yeah. And of course, as doctors, we need to always minimize patients' painful experiences. And I think getting rid of that myth that you're tough if you don't take simple analgesics is something that I certainly noticed that in practice. This has been wonderful, Jane. You are an amazing person and you're a trailblazer in Queensland. And I hope that this will be good for all of the women who suffer pain and endometriosis in the Asia Pacific. So thank you again for being part of the Aspire podcast. Thanks.
Thanks for having me, Claire.